The University of Chicago and Wuhan University have developed an extraordinary collaboration over the past 10 years called WUMER, the Wuhan University Medical Education Project, that really formed the basis for the International Medical Education Program, which is a faculty development program convened here at the University of Chicago. We were able, with the faculty in Wuhan University, to do a needs assessment for their undergraduate medical education, and then to translate that into a plan for redevelopment of their curriculum based on a reformulation of the University of Chicago curriculum for our medical school. And that process has taken over a 10-year period. We were able to take these steps by developing a group of interested core faculty from Wuhan University who were committed to developing a quality improvement program for their own medical education system. And on the strength of what we have learned from that relationship and from our relationship with the Peking Union Medical Center Hospital in China, in Beijing, we've developed the International Medical Education Program. For those of us who've worked in Wuhan for these past 10 years and in Beijing, this has been an exciting advance to incorporate the lessons learned from the WUMER project into the existing medical education infrastructure, which has a strong tradition in Chicago based on the Research in Medical Education program or the Merits program that has outstanding faculty who've committed their careers to improvement and understanding how students learn and how better to teach medicine, both in the basic science years and in the clinical years. We first developed IMEP in response to a number of requests from our colleagues both in Wuhan and in Beijing and other faculty from around China that we met who wanted to replicate the type of intervention that we did in Wuhan to upgrade their medical reform curriculum. So IMEP was born out of the need expressed by faculty members in China, but the real beginning of IMEP was the development of the relationship between Wuhan University Medical School and the University of Chicago, which began as an effort to reform the undergraduate medical curriculum in Wuhan in 2009. And we formed a relationship with the Wuhan University Medical School and brought faculty to Chicago to observe the Pritzker School of Medicine's own reforms that they had spent 5 years, we had spent 5 years reviewing and overhauling our curriculum. And the dean of the Wuhan University Medical School, Dean Zhou, made the decision that he wanted to affiliate with the University of Chicago, and we offered them technical expertise in medical education reform using the Pritzker curriculum in a modified fashion in Wuhan. And we set about to do that in 2009. And so we're now 10 years into this effort in Wuhan. Well, we're very fortunate. This may be one of the great strengths of the IMEP program, that the University of Chicago Pritzker School of Medicine has a strong tradition of medical education, both original research and application of that research immediately into the way that it teaches medical students. It's been one of the leaders in the country, and I think it's number 3 or 4 currently in the USA World News and World Report for medical education. We know that the faculty are committed to research in medical education, that they are seen nationally as innovators, and they frequently publish on different methods for improving the skills and the pedagogy for medical education at the University of Chicago. Well, for me, the greatest strength for IMEP is that it's not just a 2-week training. The faculty who have joined IMEP have committed to an effort that will take the entire year. They have brought original ideas for reform and projects to improve the curriculum from their home institutions. And we have faculty from the Peking Union Medical Center Hospital in Beijing, from Sun Yat-sen University, and from Wuhan University's teaching hospitals. And their intention is to bring those projects here to learn how to do medical education reform, how to incentivize students and faculty, how to improve the curriculum with some of the innovations that we've worked on in Wuhan and here at Pritzker, and then to bring those back to their home institutions and to apply them. And there will be longitudinal follow-up for those individuals from the participating Chicago faculty who will actually visit those cities and do follow-up in the last 6 months following the implementation of their plans.
Implement progressive reforms.
You know, we're very aware that there's enormous differences between medical education in China and the United States. Students in China begin following high school equivalent year, so they're 4 years younger than the students in the United States. They have not had the benefits of a college education. We're very aware that medical education is different in the United States and in China. In China, the medical students are 4 years younger than the college graduates in the United States. That means that they have much less world experience as well as just less maturity as individuals and are more in need of mentoring and ongoing interventions for their own well-being and mental health. That's true of many other medical systems around the world, but it's very much incorporated into IMEP because the faculty who are working at the University of Chicago on this project have experience in doing training in China. Almost all of them have either been in China or have worked with the WUMR project in the medical education reforms in Wuhan at the Wuhan University Medical School. We see that there are also enormous differences in the volume of patients that are seen in China. Very large patient populations, very demanding and stressful work situations for faculty, too little time to teach, and that's a common problem that we encounter. One other very important difference that we've seen in Chicago and in China is that medical education outcome research is itself a very lively academic pursuit in Chicago. We have faculty members who have created their careers and their research identity through investigations into medical education. We are very eager to have partners for faculty in China who are equally committed to medical education, to investigation and research in medical education, in order to show that the changes that we bring to Wuhan University, to the PUMCH hospital, that those changes are also actually associated with meaningful change for students. So the idea of pursuing medical education research as a valid outcome, I think, characterizes the University of Chicago effort. When an individual physician in China or around the world applies to IMEP, we ask them to describe their work situation and, of course, their experience, but maybe most importantly, to come with an idea for a problem that they've identified in their medical school that they would like to address, and even with a plan for what they would like to learn through the IMEP program that would allow them to formulate a plan and implement that plan in their home institution. IMEP is not just a 2 weeks training course. It's a year-long effort to develop a quality improvement plan within your own medical school, to come to Chicago to develop and formulate that plan, and then to return and implement that. And maybe the most unique feature of IMEP is follow-up in your home institution, in your city in China, where we will work with you to further implement that change. I think that's the most unique feature of the IMEP.
A large faculty.
Yeah, if your medical school has 400 clinical faculty in the clerkships, how do you begin to work with such a large group with a new plan? The idea is identifying core faculty. That's a good soundbite to have, even though these guys have all done that. Most places, I think, have started to do that.
So it would be your suggestion to the Chinese faculty?
Yeah. Well, it's interesting when you're doing an educational video, this may not make it in, but we're doing a number of things. We're selling IMEP, but we're already starting to say these are the kinds of things you'll learn. They're little teasers for what to do and how to do it. One of the biggest problems that we faced in the difference between medical education in the United States and China is just the enormous volume of patients and the equally large number of clinician educators that are working, for example, in the internships for medical students in China. And a very common question is, how do you manage to address all of the needs for change and reform with such a large number of faculty? And the answer is, very logically, not all of those clinicians are eager to teach medical students. Not all of them are actually skilled at it. So the best way to approach implementing change within a faculty, a clinical faculty, is to identify a small number of clinicians who really love to teach, they want to be teachers, and to expand on their workload within medical education by giving them incentivized time, protected time, as Dr. Stern mentioned, so that they are free to teach and to develop the curriculum. So, for example, in Wuhan, rather than working with 400 teaching faculty in the Renmin and Zhongnan hospitals, we identified 10 or 20 faculty members who cared to teach, who were interested and aggressive, who were interested also in teaching methods outside of China, in Europe and in the United States. And we worked with those individuals to become the key nucleus of faculty. And they, in turn, as a training of trainers, were responsible for bringing the remainder of the faculty up to speed with the new innovations. But in order to bring feasible change to the clinical clerkships, the first key step was to identify faculty leaders who you could work with in a small group, who could develop this new plan. We're commonly asked by our colleagues internationally to address the question of, how do you work with such a large faculty on the clinical wards in our training hospitals? And the most important answer is, you can't work with 400 different faculty, but you can work with 10 or 20 teaching faculty who you identify as oftentimes younger, more interested in new techniques, who love teaching and have identified teaching as the passion of their lives, who are interested in working on those reforms with you. And that made an enormous difference in the WUMR project. And the first steps for developing the new clinical clerkship curriculum was to have a core group of faculty that we were able to work with. We were very fortunate with the WUMR project because we were approached by the dean of the Wuhan University Medical School, Dean Zhou Yunfeng. He wanted to upgrade his medical school curriculum, and he came to us after we did an extensive training in HIV and AIDS with Wuhan University and the Centers for Disease Control in Wuhan. And he asked about the medical education system at the University of Chicago. And after he came with a group of faculty and experienced the Pritzker reforms, he was fully committed to implementing the reforms that the faculty committee came up with in Wuhan. And this made a huge difference. A key difference for anyone trying to reform medical education is to have leadership on board early and as strongly as possible. They will be invaluable to the implementation of reform efforts. And it's possible that they can't happen without having substantial reform support. So I think a faculty member would be wise to invest deeply in engaging their leadership and encouraging them and showing them essentially what they're going to do and what the outcomes are likely to be. One of the great opportunities in China at the present time in medical education reform is the ability to think about undergraduate and graduate medical education together. We've learned in Chicago and in the United States that for too many years the residency training universe was separated from medical school, and there really wasn't a lot of communication or overlap, even though they're talking about different stages of training physicians in training in the United States. Because China has just started with their residency training program, they can introduce competencies that will allow a young physician to show that they've mastered clinical medicine or pulmonary medicine, surgery, one of the medical specialties, by meeting defined competencies. And we know that those competencies apply to fully fledged senior residents, but also young residents in their first year and medical students who have completed their clerkship. And we think that establishing clinical competencies is a critical part of the medical school reform, and it can apply to both undergraduate and graduate medical education.